The title of my presentation today is Lost in Vaccination, Facts, Myths, and Building Trust. Because the idea here is that a lot of information is going around about COVID, many different types, and sometimes it gets difficult to know what is factual, what is a myth, what is uncertain and requires further research. A few disclaimers as well. In the spirit of knowledge transfer, this presentation is meant to be disseminated at large. So like we said, it is being recorded. We will disseminate as much as possible afterward. Feel free to share it with others. Just make sure to cite properly and give credit where it is due. All information shared is based on what we knew in mid-March 2021. So I tried to be as much up to date as possible. I've reviewed it throughout the week. So some evidence presented today could become incorrect and valid in the future based on new information, of course. And I declare no conflict of interest for all topics discussed in this presentation. So as of March 18, I can even say as of today, because before the presentation, I didn't see anything new. There are 4 vaccines approved in Canada: the Oxford vaccine, the Johnson & Johnson, also known as the Janssen pharmaceutical vaccine, the Moderna, and the Pfizer vaccine. The last 2 over here at the bottom are RNA vaccine, whereas the first 2 at the top here are non-replicating viral vectors. So they're slightly different types. I'll discuss briefly the difference later. So for this first part, discussing the delay of the second dose, I need to make a shout out to Dr. Don Shepard. So these slides come from one of his presentations. He gave a webinar on January 28th at the MUHC, and we asked for his permission to use the slides because they were really well done, and it's going to be easy to explain the rationale using them. So the idea at first was, why would we want to delay the second dose, right? And when that was decided back in January, back then the hospitals and the ICU rates were dangerously high in Quebec. They're much lower today, thankfully, but that was part of the rationale. The vaccine supplies are also limited, and the rollout was iffy at best even then. We have a little bit more confidence in the future as of today, but still we are in a situation of limited supply. So this asks for specific strategies. The timing of boosting has not been critical for many vaccines historically. So we're using our knowledge from previous vaccine, even though it's not the same as a COVID vaccine, to also determine our decisions. And in the short term, immunization of vaccine naive, so people with 0 doses, might offer greater public health benefit than a second dose on a previously vaccinated person. In a nutshell, the idea was that it was more important to decrease severe cases and hospitalizations than to decrease the total number of cases, right? So the idea here is basically, would you want to choose between having, 1 million people fully vaccinated or 2 million people half vaccinated, right? Like it's a 1-to-2 ratio, because it's, you're cutting everything by half. You go twice as fast by giving just 1 dose. And we figured out that at least, the government and public health believed at that point that it was worth it to go with more people being partially vaccinated, because we can live with people being mildly sick, right? It's the people that are severely sick and require hospitalization that are most demanding on the healthcare system. So protecting as many as possible before the variants take roots was also a secondary objective. So where did the idea come from? Right? It's not like it came out of nowhere. So logically, theoretically, it made sense. If you remember your immunology, right? When you have an immune response to a foreign antigen, the primary response is usually a weaker response. You can see the number of antibodies is usually lower than when you get re-exposed to an infection a second time around. So the idea here was that if you give a vaccine to someone who has never been exposed, you basically trigger a primary response into them. And then the idea was to give them a second dose so that they're already in the super high range, and then they're kind of fully immunized. But then we thought, well, if you just give them the first dose, and then you don't give them the second dose, if ever they get COVID, the infection will serve as kind of a second dose. And then that'll boost a second wave of immunity, right? So maybe the big game changer was to give a first dose. And there was research also interested in that even prior to vaccination starting. So there was a research group that looked at pros and cons of giving a 2-dose versus single-dose strategy. And among the pros of a single-dose strategy, there are things that we might not think at first hand, but such as promoting equity, right? So not everyone has equal access to vaccination. Some people might live far from healthcare facilities. We know that marginalized groups have historically been disadvantaged in getting access to healthcare. So providing a single dose to everyone first, levels the playing field a lot more. And potentially, it could have been sufficient to just give one dose to reduce the RT, which is the replication coefficient of the virus, under 1. And when you have this coefficient under 1, it means that the pandemic, the number of cases is decreasing over time. And it's not unprecedented. During a yellow fever in Congo in 2016, they also had a shortage of medication and vaccines. They decided to use a partial protection strategy to try to cover more people. Even in Quebec here, Quebec is actually one of the leaders worldwide in doing studies to try to decrease the number of vaccination required. The HPV vaccine, when it came out almost a decade ago now, required 3 doses at 3-time interval. And in Quebec now, today, it's down to 2. So you only get 2 doses of the HPV vaccine now. And we found out that you get the same efficacy with 2 doses than 3. So there were no added benefits from getting a 3rd shot. And there were people that did models. So they used projections and hypotheses to quantify what would we need for the first dose, for a single dose vaccine to be more worth it than a 2-dose vaccine. And basically using projection data and a 6-month time horizon, because the idea here is that we have a shortage of vaccine right now because it's new, but you can think that in a year from now, when it's a little bit more under control and there are more vaccines available, we're not going to be in a shortage situation, so things are going to change. So just looking for the 6 months ahead, they found out that a single dose vaccine with a 55% effectiveness may confer greater population benefit than a 95% effective vaccine requiring 2 doses. So the threshold was 55%. Basically, any new vaccine that had a 55% effectiveness after 1 dose, it was worth it to give a dose to everyone. If it was below 55%, let's say it was 40% after a single dose, then the benefits would be less than the harm. So then the strategy should have been to go with 2 doses. So what does the data say about the vaccines available? So looking at Pfizer first, when they released their first results of their trials to get their vaccine approved, they came out with a close to 95% effectiveness after their 2 doses. So first dose at day 0, second dose at day 21, and then at the end of the study, people were 95% protected. And what they saw was that, okay, and then when they looked at their data from day 0 to 21, so during the first dose interval, the effectiveness was 52.4. So if you remember from my previous slide, this is below the 55% threshold, right? So that would mean that we should go with a 2-dose strategy. But there was a caveat here. What they did was actually they looked at the average protection from 0 to 21, but they didn't account for the fact that the vaccine takes a couple of days before the effects takes off, right? So when they reanalyzed the data later, after the vaccine was approved as a 2-dose solution, they found out that starting day 14, the effectiveness between day 14 and 21 was in the 92% range, almost as good as after the second dose. So you can see that you barely get any benefits from a second dose in terms of raw effectiveness. So that's how it came that, oh, maybe a single dose is sufficient. You just need to wait 2 weeks for the effects to kick in. And the 52% actually was because in the first few days, like day 0 to 10, 11, the effectiveness was pretty much 0. So it was pulling the average effectiveness down. So it was hiding the effectiveness from after 2 weeks. We now know that it's closer to around day 12, actually, that from day 12 to 14, the effectiveness really, really skyrockets, right? And for the Moderna vaccine, the same thing, right? So after 14 days of the first dose, effectiveness is around 94. And after 2 doses, it's also around 94. Right? So now you might be thinking, well, what's the benefit of 2 doses? Well, we don't know yet. Maybe the benefit of getting a second dose is how long you get protected for, right? But right now, because we're in an emergency, it's better to have lots of people at 90-something effectiveness, and then we can all get a second dose once we have more herd immunity, right? So getting that first dose seems to be really a game changer. There are a few counter arguments, of course. Not everything is perfect. right? So there are concerns such as the small number of cases to base our conclusions on, the duration of the immunity, like I mentioned, is unknown, the quality of the immunity, could it lead to more resistance, could it favor the emergence of variants? This, I'm adding a caveat here, so a counter argument to the counter argument, although theoretically possible, so these are like valid concerns from a scientific perspective, it would be a first in history. Never have we seen a vaccine that was partially effective promote resistance. It's not the same as using partial antibiotics, which does promote resistance. Vaccines don't work the same way because they don't kill the bacteria or the virus in this case. They simply protect us. So it would be a first in history, if ever, using a single dose promoted more variants. There are also some ethical questions, of course. Is this a human experimentation? Which in some sense it is. But right now we're in a state of emergency. So, you know, our ethical questions are still very much important. It's important to address them. But we're probably going to have to be more lenient in experimenting and trying to find creative solutions. So again, these are the slides from Dr. Shepard, but I thought it was a great use of this quote from Voltaire, le mieux est l'ennemi du bien, which basically translates at, do not let better be the enemy of good. Giving a first dose is good enough at the moment. We can get better later once we all have our heads above the water. So that was for part one. Moving now to part two, the advanced considerations, or basically the frequently asked questions. So here in this section, what I'll do is I'll answer some of the following questions, such as, why do we treat vaccinated people as if they were not? Should I choose/shop my vaccine? If I tested positive for COVID already, should I still get vaccinated? And if kids are big vectors, like we hear a lot about, why not vaccinate them first? So these are all very interesting questions. So for this first part, why do we treat vaccinated people as if they were not, right? There's a few questions that tend to come like under this big umbrella, such as, am I exempted from wearing PPE post-vaccination? Now that I'm vaccinated, can I visit my parents and friends without distancing? Can I go into stores without a mask? My friend and I are both vaccinated because both healthcare workers or had access to it. Can we hang out at each other's place without distancing and masks, right? These are all things we're all excited to do, and I completely understand that. But right now, as of today, the answer is no. And there are multiple reasons as to why, but I'll go over three that I think are quite important. So one is the effectiveness of the vaccine, defining it. Two is reducing symptom severity versus reducing transmission and spread. There's a difference here. And three is social norms, which should not be neglected. So first, for the vaccine effectiveness, what does it mean, or what does 95% effectiveness or 80% or 66% or whatever, what does that mean exactly, right? When I presented the data about the first dose, two dose, I said like it was 94% effective after one dose. What does it actually mean? So in their study, so I'm taking the data from Pfizer here, but it's the same for the other vaccines. In their phase 3 data, right, that came out as like 94.8, so close to 95% efficacy. How did they get to that number? So what they had is that they had a placebo group, a group that got a saline injection versus the vaccine group. And at the end of their trial, they had 162 cases in the placebo group and 8 cases in their vaccine group. So assuming everything else is equal and that patients were randomized so that if there's any other factor, it was distributed evenly, each group should have gotten 162 cases. If your vaccine doesn't work and doesn't protect people, each group should have gotten the same number of cases, again, assuming everything's equal. So the vaccine group, because it only got 8 out of 162, it seems like the vaccine prevented 154 cases. All right, so 154 people that should have gotten the infection did not get it thanks to the vaccine. So 154 divided by 162 gives us 95%, right? So that's how you get to the effectiveness value. Now, there are a few caveats and nuances. Right? Notice that 95% is not 100%, right? You still had some COVID cases in the vaccine group, right? Although they were mostly mild. So it's one thing to protect the infection completely. It's another to reduce the symptom intensity, right? And there's always going to be a percentage of people that, even though they're vaccinated, can still get infected and can still transmit it, right? So it's not a perfect preventive method. And real life data, so effectiveness, So that's the difference between efficacy. Notice I use the word 95% efficacy here and not effectiveness. The difference is that efficacy is what you see in clinical trials, whereas effectiveness is what you see in the real world, because it's not a tightly controlled environment as in a clinical trial. So it's really, really likely, if, it would be weird if it wasn't the case, that the effectiveness is always lower than what the efficacy is found in clinical trials. That's because you have less control over the population. You have more vulnerable populations, such as elderly or pretty sick individuals that get vaccinated in the real world, whereas in your clinical trials you don't select those participants. So it might make it seem like it works better. So it's based with that information that the ENSPQ, the public health, right, on February 18th, confirmed that their strategy was working. So the data we have now with real world data from Quebec is that the vaccines have an 80% effectiveness, right? This is based on more than 33,000 CHSLD residents and close to 172,000 healthcare workers. So combined, it's 200,000 people approximately. After 14 days, you get an 80% effectiveness. So it's sufficient to pursue and to continue with mass population with just a single dose. We are above the 55% threshold as per the projection data I showed initially. Second, there's reducing severity versus reducing transmission, right? And you can see here, this is data, again, released from the ENSPQ as of February 13th. When the vaccination period started, especially in CHSLDs, you can see a quick drop in hospitalizations and deaths following the vaccination campaign. This is clearly showing that the vaccine protects against severe cases and hospitalizations. This is the sort of graph we needed to see, right, to really confirm the real world effectiveness. And it could not be more promising than what you see there, right? But again, it's not perfect. I'm taking this as, that was on one of the articles in La Presse recently. It always frustrates me when they have those kind of clickbait titles, right? An éclosion, there's an outbreak in a CHSLD despite vaccinations. That's how it translates to. But then when you actually click on the article and read it, what you find out is that it was actually showing how the vaccine works, right? Because remember, you can get cases after getting vaccinated, but the most important is that the cases are mild. If that's the case, it means the vaccination works. And this happened in a CISS in Outaouais. 96% of the residents were vaccinated at the time of the outbreak. They had received their first dose. But only 40% of the PABs at that CHSLD had accepted the vaccine. And what it meant is that prior to the vaccine, right, the death rate in that CHSLD, which had actually gotten an outbreak in the first wave, right? So back in March 2020, they had an outbreak. They had 64 cases, 17 deaths. So that means it's a 27% death rate. As of March 12th, right, so following this outbreak that came out recently, they had 48 cases and 7 deaths. But one of those deaths was one of the few residents that actually was not vaccinated. So when you take the 6 deaths of vaccinated people out of 48 cases, it comes down to 12.5%. This is half, right, in a very, very vulnerable population. So it was actually showing that vaccines work, despite what the title is kind of insinuating at, thus the clickbait, but whatever. We're not in media for a reason. Vaccine does not prevent transmission infection completely. Remember, there's a difference between reducing the severity of the symptoms rather than preventing you from transmitting the virus. And the ENSPQ suspects that it was brought in by a healthcare worker. Remember that only 40% of PABs had accepted the vaccine. So it's not because the residents were vaccinated that they couldn't get it, right? They were more protected, but still vulnerable. So that's why even if you get a vaccine and you are protected as a young individual with low risks, you could still transmit it to someone else who is at high risk, right? So maintain all precautions and advocate for vaccination in your neighborhood, in your unit, wherever you are, as much as possible. I'm just presenting this slide quickly because we are starting to see evidence that the vaccines also decrease transmission, right? So we know that the vaccines are good to decrease the symptom severity. We're pretty confident it will also decrease transmission. We just didn't have the data to claim that yet. We're starting to get it. So you can see here the difference between the 2 points here happening around day 12 or 14. It shows that the number of viruses, so the viral load, is actually lower. I know the graph shows like it's higher, but it's actually like the way they calculate it's a negative value, so that the higher it goes, the less viruses there are. So that you can see the difference in viral load between day 12 and 14, clearly showing the vaccine is working. And we have data from the UK also promising, but it's not a peer-reviewed article yet, so we need to be cautious with our excitement. And then the third argument, remember, was the social norms. We're entering an awkward transition phase where some people are vaccinated and some are not. All right. And during that time, same rules should apply to all, regardless of the vaccination status, until a critical mass has received it and we have achieved herd immunity. The reason is that imagine you're in the street and you decide that because you're vaccinated, you don't wear your mask, you don't distance anymore. People don't know that. Other people don't know you're a nurse or a PAB or a doctor or any other professional that had access to the vaccine. They see a young person who they know from media should not have received the vaccine, unless special circumstances. So their first assumption is that person's cheating. They're not following the rules. Why should I follow the rules as well, right? We're all excited to stop doing that, but unfortunately, it's not the time yet, right? It promotes solidarity, it promotes social trust and conformity, and it avoids the need for verification, having a vaccination passport, which could lead to kind of like a very privileged few that receive the vaccine and can do a lot of activities while all the others wait. It's actually, it makes sense from a logical perspective that healthcare workers should be the first ones to get the vaccine, right? You're putting yourself on the front line. But that also comes with responsibilities of you also had a privilege of getting the vaccine first, right? It's to compensate for you being on the front line, but it's not to give more extra privilege of attending concerts or hang out with friends before other people, right? You still have to maintain a high level of regard for the healthcare profession and lead by example, basically. And we know that social conformity is really powerful. For those of you that took my lectures on social psychology, you can review the experiments from Ash and Milgram's, the obedience experiment, the social conformity experiments. We have vast amounts of data in social sciences to show that people follow, right? In English, they say monkey sees, monkey does, right? So if you start seeing people that don't apply the rules, many people will stop following. That doesn't mean you can't use the fact that you're vaccinated smartly, right? If there's a vulnerable individual in your family close to you that requires a caretaker, and the choice is between you and, say, your sister, your brother, your mom, your dad, that did not get a vaccine yet, well, you should raise your hand and it should be you, right? You're vaccinated. But, right, you should still keep wearing PPE and you should still distance as much as possible. It's all about mitigating risks. And wearing PPE and distancing are still easy ways to mitigate those risks until we're really, really, really sure, right? Why take this risk? To the question, should I shot my vaccine? All right, like a quote that you could hear would be, I don't want the AstraZeneca because it only had 66% effectiveness. Today, this speech could be actually like, I'm scared of the adverse effects because of what's happening in Europe. I'll get back to that a bit later. I want the Moderna Pfizer vaccine that got 95%. I'll pass if they offer me the AstraZeneca until I get the fully effective one, right? This is a flawed reasoning, and here's why. First, I'm bringing back the quote here, right? Le mieux, l'ennemi du bien. It's better to get 66% than 0% in all cases, right? So that's just for one. Two, the 66%, again, is not the full story. If you kind of break down the data, you see that the AstraZeneca is just as good at decreasing symptom severity as the Moderna and Pfizer for the severe cases. It doesn't work as well for the milder cases, but once again, the most important right now is to protect people against hospitalization, and for that, it does just as good as the other vaccines. It's slow. If someone refuses the vaccine, it slows down the herd immunity process. It's still possible to receive other vaccines later, right? You can get the first dose with AstraZeneca, and then in a couple of months when things are under control, if you want to go get a Moderna Pfizer, you're probably going to be able to do it. There's no data suggesting that there's an added risk of adverse effects by mixing the vaccines, right? it could actually be even safer and enhance protection. There are some preliminary data from Oxford coming out that are suggesting that. It's the first study that are testing 2 different vaccines in a single person. And what they see is that it's potentially attacking the virus from multiple angles, having a synergy. So it could actually be beneficial to receive 2 different types of vaccine, one that is RNA and one that is not. If I tested positive for COVID already, should I still get vaccinated? The answer is yes. Right? There's no data suggesting a greater risk. COVID reinfection cases have been reported, so it's not because someone got COVID before that they can't get it after. So we have cases from people that got infected early on in the first wave that got it again over the summer or this fall. Antibodies seem to last 3 to 4 months on average when you get an infection. And it's possible to offer stronger immunity after just 1 dose. Because remember, if you tested positive for COVID before, right? That means your body is primed. They already had this kind of primary response. So if you were to get the vaccine, it could actually count as your 2nd dose of a vaccine, right? So maybe you wouldn't even need a 2nd dose later, but you need that 1st dose to really boost your immunity to maximum power. So yes, you should still go get vaccinated. If kids are big vectors, why not vaccinate them first? So this is actually a good question. There's a few answers here. Historically, we've tested new drugs on adults, right? So that's first thing. We don't have data for kids. There's not many parents that want to volunteer their kids for experimental drug trials. 2, recall the symptom reduction versus transmission reduction, right? Kids might be transmitting a lot, but they have milder symptoms. So for them to receive the vaccine at the moment, remember, it's possible the vaccine will reduce transmission, but at the moment, we're a lot more interested in reducing symptom severity. And for kids, because their symptoms are either none to pretty mild, the potential benefits are low. You can't lower the bar much lower than mild. And the transmission reduction is less certain, less documented. So it was a trade-off there. So again, the most urgent is to protect vulnerable population, reduce hospitalizations to alleviate the healthcare system. So that's why we're going with older populations first. All right. So in conclusion, we have a long-term societal problem at hand. I've put in the references, the resources at the end. There's a very interesting documentary. It's only in French, unfortunately, but it's called Aiguille sur Roche that came out that I watched recently. And they do a pretty good job at looking at all different sides. And at the end, at some point, they said, we need a huge societal couple therapy, right? So the government and a group of the population, they need to get into a room with a psychologist and settle their differences. It was a pretty funny bit there, but that's in the long term. In the short term, what you can do is you yourself get vaccinated as soon as you can, keep wearing PPE, we just have a couple more months to deal with that, but we can't give up so close to the finish line. So be leaders in your own place. Right, the end is in sight. Must not let our guard down. That's coming from the Glen directly. As a healthcare worker, you have an opportunity to lead by example and exert influence over your community and your peers. So grab on that opportunity. And thanks for listening. A lot more resources here from this talk. So this will be available as well if you want to get more detail on certain data, or for example, that documentary mention more details on the motivational interviewing technique by the vaccine whisperer, Professor Arnaud, also there. These are extra resources from Professor Marchioni as well if you want to get more data on certain aspects. And I want to give a big shout out to my collaborators. So Caroline, Leah, Ugo, Rena, Dr. Shepard also for his slides on this delaying the 2nd dose. Big thank you for making this happen. And without further ado, I will stop sharing my screen. And now I'm tired of hearing myself, probably, or you. So I'm going to leave it up to the floor to ask questions. Hopefully you appreciate it.